Our first presenter is Dr. Lyons from the University of Texas Medical Branch, and he is going to present on an insoluble problem.
Great. Hi. Thanks for having me here. My name is Lance Lyons. I'm from UTMB in Galveston, Texas. My first slide, I have no financial disclosures, but I'm actively looking for some.
Good for you.
We'll start with a 45-year-old white female who was previously healthy until 2012, who developed a chronic, progressive, painful, bilateral, sequential complete ptosis and pupil-involved ophthalmoplegia. This started after tooth pain. She had a dental abscess and multiple dental procedures. We'll dig into this in a little bit. Her past history, basically non-contributory except for strabismic amblyopia, childhood strabismus. She had strabismus surgery in childhood. She was taking medications, ibuprofen only, for this sharp stabbing right V2 distribution pain that she was describing. She denied the bad habits, and her family history was non-contributory. So to start, in 2012, she had this stabbing sharp right V2 pain. She went to the dentist who recommended a wisdom tooth extraction. She also had a right tooth filling, but there was no relief of the pain. She also was noted to have exposed bone post-op from the procedure. The dentist diagnosed her as having a secondary osteomyelitis and sinusitis. She was treated with antibiotics. 2 years later, she had worsening of this chronic pain that never really got better, and then she developed a right facial droop. In February of that year, she had more dental cleanings and fillings. After the dental surgery, she developed bilateral ptosis, right headaches and facial pain, and a right blepharospasm, which she described as her lid twitching. In the summer of that year, she had more dental surgery, a root canal in 3 sessions, and subsequently developed a right ophthalmoplegia after the surgery. Finally, at this point, the patient was worked up. She had an MRA head, which was essentially normal. They just found an incidental cyst. An LP looking for demyelinating disease was negative, and a full PET scan was essentially negative. There was a low uptake in the right costophrenic angle, which was biopsied and was negative. It was only fibrosis. She then was evaluated in an outside hospital who did a full workup, including serum studies, which showed an increased IgM. She had no Bence-Jones proteinuria. Her beta-2 microglobulin, her serum M protein cryoglobulin, VEGF for POEMS was drawn, which was also negative, and a full autoimmune workup was negative. She had a negative skeletal survey and therefore went for a bone marrow biopsy, which found an uncommon diagnosis, a biclonal gammopathy with less than 5% lambda-restricted plasma cells. Therefore, even though she complained of no cardiac symptoms, she went for a cardiac workup. Her ejection fraction was normal, and she had a normal wall thickness. The right dorsal foot and left and distal left epidermal nerve fibers, which are accessible, were biopsied, which were negative, including for amyloid with Congo red staining. In January, she undergoes another left tooth extraction and then develops a worsening of the left-sided ptosis. She has a CT scan that shows maxillary sinusitis and then goes for sinus surgery with ENT, including biopsy for amyloid, which was negative, and developed a left ophthalmoplegia. She had a second MRI brain, which just showed the stable middle cranial fossa cyst, and specifically no cavernous sinus abnormalities were found. She had repeat studies looking for another area to biopsy, basically. A PET CT was negative. She had a third MRI brain orbits, which was negative, and the continued workup was negative. She undergoes another right-sided tooth extraction, which was a suspected infection from the previous tooth extraction, and then is treated for skull-based osteomyelitis throughout the summer with IV antibiotics. She then presented to our hospital. On examination, she was found to have the amblyopia on the left. Her pupils showed a little bit of light near dissociation, but were essentially non-reactive. Her intraocular pressures were normal. Here is a picture of the patient she was using lid crutches at the time to keep her eyelids open, but she had a bilateral complete ptosis. You see in primary gaze, she has about 25 prism diopters of right hypotropia, which increases to about 30 on up gaze. Here I'm just showing you that she has a bilateral ophthalmoplegia, right worse than left. You can see in these pictures in left gaze, she has almost complete adduction deficit. She had an asymmetric nasolabial fold from back when she had the facial droop. She did have a temporal pinguecula, which I only point out because it was considered as a possible biopsy site at the time. The cornea showed no evidence of amyloid deposits. There was no anterior chamber reaction, and the rest of her ocular exam was normal. Here I'm showing you an MRI. This was read by a specialist in the field who pointed out greater than expected marrow enhancement within the skull base, clivus, petrous apex, mandible, and the sphenoid triangle. This is suggestive of infiltrative marrow disease, which can be secondary to amyloid, monoclonal gammopathy, or possibly reactive marrow. Here I'm showing you the clivus. I don't have a pointer, but it's there. And here's the skull base. I'm showing you this because if you look at the left superior rectus in comparison to the right, you'll notice it's enlarged. We'll get to that in a moment. Okay, subsequently, she goes for another dental biopsy of the right maxilla, and she was found to have culture-positive polymicrobial osteomyelitis with erosion of the floor of the sinus, and she's continued on all of these IV antibiotics at some point in her course. She also received 15 sessions of hyperbaric oxygen, which we had to discontinue because of worsening headaches. And her diagnosis at this point was a skull-base osteomyelitis after dental procedures. The summary to this point, this was a 45-year-old previously healthy Romanian female who developed right stabbing sharp V2 distribution pain. She had dental surgery on the right, developed right-sided ophthalmoplegia and ptosis. She had dental surgery on the left, then developed left ophthalmoplegia and ptosis. Her MRIs were essentially negative, save for what was read by the specialist. And LP and the systemic workup for the usual suspects was negative. At this point, I'll pause for comments.
Well, one point that you did mention, but I think deserves a little emphasis, is if you've got ophthalmoplegia, you want to know whether it's pupil involving or pupil sparing. And especially in a situation that's bilateral, involving all, I really was expecting this to be pupil sparing. Pupil involving ophthalmoplegia is much more likely to mean that you've got a mass lesion, but you got all these MRIs that says the cavernous sinus, and what are the odds that the cavernous sinus on both sides would be involved? Arachnoid cyst is incidentaloma.
Mm-hmm. Yeah, the involvement of the pupil did point us to a more neuropathic process and essentially removed myasthenia or thyroid from the differential.
So you're calling these cranial nerve palsies or orbital? Are you calling it ophthalmoplegia from cranial nerve palsies or from an orbital process, or maybe both? Or
yeah, perhaps both.
Perhaps both.
But for sure, multiple cranial neuropathies, bilateral.
Alfredo, what do you think about in multiple cranial neuropathies without imaging findings?
That's a good title for this case. Clearly, you want to go maybe to the orbital apex to have this, but it's fine. And what is going on, maybe more metabolically, would not be affecting the pupils. So these are almost contradictions, that you have all this dysfunction without a structure to go along with it.
Any next steps? Lumbar puncture? Would you biopsy
did a
the
lumbar
superior
puncture, right?
rector? Once.
Normal, yeah.
Right.
Yeah, I would actually do another with a cytospin, because I think paraneoplastic disease is sort of the least amount of structure that gives you the most amount of dysfunction, and that's where I would be looking.
What about creeping squamous cell? Would that fit with this presentation? Alfredo, what do you think about that entity?
Yeah, again, well, I think what I'm doing and you're suggesting is to look for the most bang for the buck, where you can get the most dysfunction with the least amount of structural abnormalities. But maybe even more importantly, what are the tests that'll get to that? And that's one reason I said another LP with cytospin would be a useful approach.
But again, I am no oculoplastics or orbital person, but each time the ophthalmoplegia develops really temporally closely related to the dental procedure, right? If this was osteomyelitis, you would expect slowly progressive, perhaps, involvement. But each occurrence, at least from what I got, is immediately after a dental procedure.
The patient was adamant that the dental procedure was causing it. So for sure, she said that the dental procedure preceded the ophthalmoplegia, but in her mind, it was causing it. But as to the exact temporal relationship, it's kind of unknown.
And she was getting local or general anesthesia for these procedures?
Local.
With an infiltrative anesthesia.
Mm-hmm. Mm-hmm. Which was also thought of on the differential.
Where was the injection?
Usually they go underneath the lip.
All right, why don't you keep going and tell us how this turned out?
Okay.
Very posterior.
I know there's probably a lot to talk about on this case, but if we can go back to the slides, I'll show you what the next steps were that we took. So basically, the main differential at this point was a secondary expansive osteomyelitis that was creeping into the orbital apex, which we had culture positive proof for, or a secondary process given her biclonal gammopathy, which was found on the bone marrow studies. And the only way to adjudicate this was a biopsy, and it was thought that the best biopsy site was that left superior rectus that I showed you in the MRI scan before. She had that orbital biopsy on the left, and as a hint to the diagnosis, after the biopsy, she developed bilateral subconj hemorrhages. Even the eye that was not operated on had subconjunctival hemorrhages. This is kind of classic for what the final diagnosis was. Here we're looking at the skeletal muscle. Here there's a lymphocytic infiltrate, no carcinoma was seen, but here in the bottom left of this image, you'll see a stain of Congo red for amyloid, which was positive. She was found to have AL-restricted, orbital-restricted amyloidosis. And then in situ hybridization showed basically kappa-positive cells with scattered lambda-positive cells. The final diagnosis was a small B-cell lymphoma with plasmacytic differentiation with amyloid deposit in the orbit.
Did they have difficulty stopping the bleeding when they did the biopsy?
I don't have the exact
I've seen a couple of times where that led to the diagnosis, because in these cases with the amyloid, they just don't get the capillaries, the arterioles won't constrict and won't stop.
Yeah.
So Alfredo, where is the amyloid that's causing her ophthalmoplegia or her lymphoma?
I'm assuming that it is involved in the vessels and is producing ischemia.
Could the anesthesia be, with the dental procedures, exacerbating it somehow? No, right?
Anything's possible. I don't see it.
Yeah, also the problem was that even after what the half-life would be expected for the anesthesia, she had this for multi-year. This was a chronic process, and there was some enhancement in the dura of the bilateral cavernous sinuses that was also thought to be amyloid deposition affecting the third cranial nerve and the efferent pupillary pathway.
Those pictures are too low mag, but in such pathologies, you will often see this ring of Congo red in every little arteriole.
Any final comments? How's
Thank
the
you.
patient doing? Or
She's doing well. She is still being followed up. They're watching so that this, gammopathy of uncertain significance doesn't turn into a gammopathy of certain significance. But otherwise, she's doing well and still being followed up.
excellent. Thank you very much.
Thanks so much for having me.